This week on the Back Table Podcast.
You have to counsel them about the known factors, possible risks, and it's a surgical procedure. We still don't know. We don't know a lot of things, but I think it's so exciting.
Yeah.
Because if you're able to provide natural hearing to this child instead of them needing a cochlear implant, that's incredible. That's incredible. And I think that's opening the doors to a lot other studies and encouraging a lot of people that, we're going to be able to do this, which is crazy.
Hello, everybody, and welcome to the Back Table ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and I have an awesome guest today. I have a fellow pediatric ENT. I have Dr. Daniela Carvalho. She's a pediatric otolaryngologist practicing at Rady Children's Hospital in San Diego. She's the director of the Cochlear Implant Program there, and she's here today to talk to us about some of the newer indications for cochlear implants and what's new and innovative in gene therapy for hearing loss. Welcome to the show, Daniela. How are you?
I'm great, Gopi, and this is such an honor. I'm thrilled, absolutely thrilled. So
happy to have you. Can you first tell our listeners a little bit about yourself and your practice?
Of course. So as you mentioned, I'm Daniela Carvalho, and I'm a pediatric ENT for the past 20 plus years. I work at Rady Children's Hospital, San Diego, where I'm your partner. Very proud to say that.
I'm prouder.
And I am also the director for the Hearing and Cochlear Implant Program. We've built this and developed with a wonderful team. We have an amazing team there. So, it's a lot of fun and taking care of the kids and doing good things, I hope.
All right. Just to kind of set the stage, tell me, how do you explain congenital hearing loss to your patients, the families that come in to your clinic?
That's a really good question, because I would say, the first thing that the parents come in and ask is not as much how can I treat it, but it's how did this happen, right? It's their first question. So I think for us ENT, it's really important for us to have an idea of how to explain it. So if you're talking about sensorineural hearing loss, bilateral sensorineural hearing loss, you need to explain to the families that most of them are going to be genetic. So about 50% of these kids are going to have genetic hearing loss. And of those, about 50% or more, some people say 2/3 are going to be recessive, non-syndromic. Because the first thing you say, when you say that, their reaction is, but there's nobody else in the family with it, right? And then you have to explain, well, do you remember back in high school, and go through the whole thing, and there's no other symptoms but hearing loss. And then you're going to have about 20 or so percent that are going to be syndromic. Some of these syndromes can be apparent, so you can have some features, and some are not going to have anything that's phenotypical on, a characteristic in their face or hair, like Waardenburg's, for example. So you need to have an idea of how to examine and explain to the family as well. And then there's also about 20% of the kids, they're going to have hearing loss due to congenital CMV. I think we're going to chat a little bit about that too. And then the other few that are going to have idiopathic, or as we know, we doctors or we humans still don't know what's going on, and we're still trying to find out why they have the hearing loss.
When do you usually see these patients? Or is it usually within that first 6 weeks? I mean, we have the newborn hearing screen. You might have a confirmatory, but when are these kids coming into your office, and what percentage of those group of kids is a unilateral, bilateral, mild, profoundly severe in your practice? What do you think the numbers are there?
Right. So I think, because we have newborn hearing screening, thank goodness, right? Because hearing loss is a invisible problem, right? Until you have issues with speech delays, which is what we had in the past. So because of newborn hearing screening, and I think we need a little addendum here, is that we in the U.S. are actually doing a pretty good job. So about 95, 98% of the kids are screened. The problem is after, but we won't get into details about that. So when they fail newborn hearing screening, then they come to us. This is going to vary a lot depending on where you practice, of how old they're going to be when they come to see you. If they have congenital hearing loss and fail newborn hearing screening. Because you're going to have the kids are going to have progressive hearing loss, and they're going to come to you later. I would say that the vast majority, about 80% or so, are going to have congenital hearing loss, so they failed the newborn hearing screening. They come to see you. In my practice, we have a system that all the birthing hospitals here in San Diego have their diagnostic testing done through us. So we are able to see these kids pretty early on, sometimes around 4 or 5 weeks of age, sometimes even sooner than that, which is great because you know how important it is to diagnose these kids early, right?
What percentage, and this is the kids that come at like age 3 to 5, kind of getting into the CMV, delayed onset, how do you navigate that workup and counsel that family?
So for the older kids, it's a little tougher because they're going to be either going to have speech issues or that the parents tell them, the pediatricians. And I think this is very important, is listen to the families, listen to the parents and test them. You have any speech delays, test their hearing. We do see a lot of pediatricians that don't test them and some ENTs as well, which to me is a little surprising. So please, please, please test all hearing, for kids that have any speech delay. But for the older kids, so if they fail the screening at their pediatrician's office, you want to make sure that their ears are clear because the most common cause for hearing loss at that age is going to be middle ear fusion. We can take care of that. Everybody knows, how to do that. We're going to set that apart. But for the kids with sensory narrow hearing loss, the ones that have congenital CMV, again, that were not diagnosed at birth because they didn't have any screening for CMV, they can come with unilateral hearing loss or asymmetric hearing loss. You cannot diagnose congenital CMV if they were not tested by 3 weeks of age, and that's a problem.
Danielle, is there a role for the dried blood, like the cards, and are the states holding on to them for that long? And is there a role for that?
Yeah, that's a really good question. So because you can absolutely test them with a dry blood spot. And they're saying that actually the sensitivity is not that low. They were concerned about it was about 70%, but some people say that it's higher than that as far as the sensitivity goes. So you can do PCR for CMV and a dry blood spot. The issue is the way the states manage the dry blood spots is very, very tremendously. And here in California, for example, they keep it forever. I don't even know how they do it. And we had a wonderful system. And for some reason, recently we've had some issues with the biobank. They don't have a lot of people working there, and we have not been getting a lot of results. So again, even within a state, it can change. But that's the one way that you can test them is to actually go back to the dry blood spot and do a CMV test.
Do you have to call? Who do you call? How does that?
So I know how it works. I know. Who do you call?
I'm like, so what does that mean?
I know, right? It will depend on the state.
Okay.
So I know here in California how it works. There are some forms, and whoever is listening to this, if you're from California, feel free to contact me. I can give you all the details. In other states, I'm not sure how they do it. I mean, because you have to send the biobank or wherever those dry blood spots are, they have to send it to a lab. So
yeah,
I'm sure that there are different ways in different states. I just don't know how to do it.
Yeah, and every state doesn't carry the cards. Some states might be 5 years, some might be, I don't know. So that's also variable.
Exactly. But it's worth a try.
Yeah.
Yeah.
Talk to me a little bit about how the indications of cochlear implants have changed in your practice. I think traditionally of the bilateral severe to profound kid that doesn't get, baby that doesn't get benefit from the hearing aids. But have we expanded our indications? Tell me how you do it now.
We have. And I would say I'm old enough that I've seen a lot of changes. So back in the 90s, it was only approved for bilateral profound sensory narrow hearing loss in kids that were older than 2 years of age. Yeah. And then 98, that changed to 18 months. And then in the 2000s, it went down to a year. Despite the fact that everybody knew and had data already showing that it's important to give kids access to sound early on, right? So in 2000, it became approved for kids that had bilateral profound sensory narrow hearing loss after a year of age, right? So 12 months, or severe to profound after 2 years of age. So that's 2000. Fast forward 22 years, right? And now we're down to 9 months. And because the way the FDA sees cochlear implants, it's manufacturer-based. So, for example, Medell got approval for a unilateral profound. They were the first ones at 5 years of age, which is kind of a really weird thing. We can talk about that too, because to me, it makes no sense. In 2022, then Cochlear Americas got approved for cochlear implantation in babies that had bilateral profound hearing loss at 9 months. So it is reducing that as well. And I know of a lot of places, including us, that do off-label at 6 months and unilateral. If you have a unilateral profound hearing loss, we're trying to implant as early as possible. It makes no sense to leave the child with no hearing in 1 year and then try to implant it at 5 years of age. So lots of interesting things because of our regulations, I would say.
What is the reason? Do they provide a reason?
They didn't. And if I would say, in my opinion, this is me, but I think, the industry is really trying to push forward with it. And I can say that because there's so many red tape and it's so complicated to move things forward in that regard, it's probably easier for them to say, okay, let's do 5 years instead of saying that we're going to do 2 or 1. Because look how many years it took for the FDA to change the guidelines for age, for bilateral profound. And with us having an enormous amount of data showing the advantage of having access to
binaural access.
Binaural, exactly. Yeah. Bilateral, yeah.
Is there a role for cochlear implants in kids who have some residual hearing or moderate to severe that don't have benefit from hearing aids? Do you have kids like that?
So what we have are kids that have a high-frequency hearing loss, so more like a sloping hearing loss. I have a lot of kids that actually have near normal hearing in the low frequencies and then very slow, very abrupt hearing loss in the high frequencies. Those kids struggle tremendously.
Yeah, are those like the kids who have maybe had chemo exposure?
Yes. So your example is perfect. So a kid that had ototoxicity for one reason or another, so it's going to be more high frequencies. Loud noise exposure, so usually it's not as much. Yes. Although, there's some studies showing that there's a high percentage of teenagers that already have hearing loss due to that. So if there's anything that we can do with our patients is tell them to decrease the volume of everything that they listen to, including us. Also, there's a lot of genetic causes, we think, there's some that are known, some that are still being investigated, that can cause this kind of sloping hearing loss as well, symmetric. So these kids have to go through the whole cochlear implant evaluation if they're not really benefiting from hearing aids, if the hearing aids are not able to provide them with access to sound, or they're already having issues with word discrimination. That's another issue too. So you might be hearing in a moderate severe range, but your word discrimination is really poor. You might be a cochlear implant candidate. But these kids need to go through the whole evaluation to make sure that that's the right thing for them. So,
No, that's super interesting. Tell me, in terms of cochlear implants, as you mentioned, there's, a couple of different main companies out there. Have you noticed just with the device itself, what kind of technological improvements or changes have you what are the features now?
So as all of them, right? Bluetooth is a big one. Yeah. All my kids, anytime I say Bluetooth, they're like, really? Yeah, their ears go, yes. So Bluetooth is one. I mean, they have a lot of features that you can connect to your phone and change the way, what type of programming you have in your cochlear implant. You also have that with hearing aids. But I think the biggest changes are in just the speech processing, which has evolved tremendously. There's even talk about using AI to help with the processing as well. And that has made cochlear implant technology much better over the years. So I think there's a lot of incredible things that are going to happen. Also, there's a lot of people working and trying to have completely implantable cochlear implants, which is also something, despite the fact that cochlear implants are getting smaller, right? And they are really cool looking. They really are. They're beautiful devices, but you still have the stigma. Some kids don't like to wear it. You go through teenager years and they're like, I don't want this in my head. So maybe having a totally implantable cochlear implant will be an advantage. I don't know. We'll see. We'll see. But that's also something that's coming down the pipe. So
in terms of speech processing, if that's better, my word discrimination, all that improves. Is that what that means?
Yes, absolutely. And also one of the things that patients with cochlear implants sometimes struggle with is just enjoying music, right? Because cochlear implants are really great with rhythm. So speech that is based on like rhythm, so English, for example, right? You have much better results than, for example, in Chinese. So Chinese is a more tonal language. I think that these things are fascinating.
Yeah, this is super. I've never even thought about that.
Yeah. So all these things, if you improve your speech processing, you're going to be improving all of that too, including just the music perception and ability to enjoy it too.
Wow, that's great.
Yeah.
All right, so getting into some gene therapy for hearing loss, where are we at with that? What are we talking about? Which genes? What's been going on?
I would say this is one of the things that, I get teary-eyed. It makes me emotional because I never thought that in my lifetime I would see this. Every time the parents would come to my office, I would say, so here are the options. And they would always ask, what about gene therapy? I said, well, there's really nothing out there right now. But guess what? There is now, which is insane. It is insane. So the gene therapy that's being tested in kids right now, it's very specific genes. So there's several ways. If we go back to the causes for hearing loss, right? I think we need to kind of set the plane there. So about 50%, as I said, so two-thirds are actually going to be autosomic recessive, right? And then you have the kids that are going to be connexin positive. Of that group is the biggest group. So anytime you look at a type of therapy, everybody's trying to treat the one that's going to help the most people. But treating connexin, the genetic therapy for that's going to be tricky. There's a lot of reasons for that. We're not going to talk about this, but they're working on it. So I think just by the fact that we have something going on right now, and we'll go into the details, we're just setting the stage. We're like, come on. I think there's going to be something coming up for connexin. But what they have done is they had to try to find first an animal model that would work well for testing, right? And then go from that to humans, as we always do. So with connexin, for example, the animal models, usually, for example, with the most common genetic mutation for connexin, 35-DEL-G, mice usually don't survive. So
interesting.
Yes, I know. They're and again, I'm not somebody who's doing all these tests or in the lab like these amazing PhD folks. They're just incredible. Thank you for doing that. But I know that that's one of the cases, and they're trying to find a model that will work for that. They found a gene that will work well for mice and would also, the other structures in the cochlea and the auditory nerve, everything is perfect. So if you repair that gene, then you would be able to repair the function, the auditory function. So that's otofurlin. It's a OTOF. That's the gene. And OTOF codes otofurlin. So otofurlin is a protein that helps the inner hair cells send the neurotransmitters to the nerve, right? So if you have OTOF, an abnormal gene in there, it's not going to be sending that information to the auditory nerve. Usually these kids have what we call auditory neuropathy, which is a type of sensorineural hearing loss, but we're not going to get into the super details of that. OTOF causes about 2% of sensorineural hearing loss. So it's a small percentage, right? But they have shown in mice that when you treat it, when you're able to send the genetic material, and I'll talk about that, it's just so fascinating. I can't even be here all day. But if you can send that genetic material to those cells, they can start producing otofurlin, right?
Right.
And they showed that in mice it lasted for a long time. So it's really promising. Here's the crazy thing. So The genetic material, so the way you send this genetic material to those cells is, in this case, is through a virus, right? So it's a vector, okay? So it's called AAV, which is associated virus. I might be saying it wrong, but something like that. The genetic material is too big for one virus to carry it.
Oh, okay.
So those guys broke the genetic material into two and put it in two viruses. And then you inject those viruses into the cochlea.
So is that like make a myringotomy to the round window?
Yes. So no, it's a little more complicated.
There's more than that. Okay.
So just let me go to the gene part and we'll go to the surgery part, because that's a very important question, because you think genetic therapy will be this thing.
I'm thinking systemic,
drink a syrup,
oral.
IV.
Now I'm like, oh, this is like direct.
Yes.
Yeah. Okay.
Yes. So a little more complicated. Yeah. So those two viruses go into the cell. They have something called a promoter. So because you think, okay, if you have a virus going into your body, what if it puts that genetic material somewhere else that you don't want to? So they have a promoter. It's really crazy.
It's like it guides it to where it needs to go.
Exactly where it needs to go. And then those two, the genetic material will join and become OTOF and go into the cell. And voila, magic.
And it's making the inner hair cell release whatever neurotransmitter it needs to the nerve. To the nerve.
Correct. So how do you do that?
Right.
Yes. So there are several different ways, because the beauty of this is there are several different companies doing it. Gotta love competition, because they're all trying to race each other, right? The race has been on since, I think they started with some of the results back in late last year.
Okay.
And there are several kids already that have had this done already.
Okay. So now we've gone from mice to patients.
Yes.
Okay.
Yes, several children already treated. Okay. So the way you do it is you have to inject that material into your cochlea. Yeah. So it's injected into the perilymph through the round window.
Okay.
Right? But because you're injecting something, imagine, so injecting something into a closed cavity, if you inject it and you have anywhere else for that to be released, it's going to come back at you, right? So you have to create some opening.
Okay.
So there's one company that creates the opening in foot plate. There's another one that makes a small opening in your lateral semicircular canal.
So it's kind of like a release valve.
Correct.
Kind of like when you do intratympanic steroids, you need a release valve. Maybe.
Exactly.
Okay.
No, totally.
Okay.
Totally. No, yeah,
right.
that's a grid. That's exactly it. So, so different techniques.
Does it matter where you place the release valve in terms of causing damage to hearing?
That's what they're looking at.
Okay.
So, we are actually at Rady's, we're part of a study from Regeneron, and they do an opening in the lateral semicircular canal. So the axis is almost like a cochlear implant.
Wow, yeah.
You do a mastectomy, you have to, make a small opening in the lateral semicircular canal. You open your facial recess.
Okay.
Yes. And there's another company where you do it trans canal.
Okay.
And then you make that opening in your foot plate. So there's a Chinese company, there's in France. I mean, it's great. Competition is good. Yeah. I think we'll have, and there are tons of kids now that are being enrolled in these trials. They did unilateral, now they're doing bilateral. And so the question is this, because we don't know the long-term results, right? How long is this going to last? I think the questions that we all have are, we don't know how long this is going to last. We don't know exactly, will these kids need maybe hearing aids, which, hearing aids can be better than cochlear implants in terms of depending on the level of their hearing, right? If you have natural hearing, it's always going to be better than electrical stimulation, right? Side effects. So you're injecting a virus into your body. I mean, you're going to have any reaction to it, so they're also measuring all this as well. So far, they have not seen any complications in that regard. And the AAV, which is a vector, is a very, as they say it doesn't cause as much immunogenic response, which is good. There's some other ways that people are looking into also either adding a gene or modifying a gene. There's CRISPR, there's like nanoparticles. There's a lot of different things. But right now, so these are the things that I was talking to my patients before this all started. And right now, this is the only treatment it's not FDA approved yet, but it's being undergoing a lot of tests in humans.
So in terms of who is going to be a candidate, so are these kids, what degree of hearing loss do they have to make them qualify for gene therapy? And if they've already had a cochlear implant, does that take away that chance? Does it help them? Like, how do you put it together? How do you apply it now? Because where does it fit?
Right. So again, ideally, you want to do it early on because these kids that are positive for otofurlin, they have bilateral profound hearing loss. So to be enrolled, you have to have bilateral profound hearing loss and auditory neuropathy. So you're going to have cochlear microphonics and, the abnormal ABR and so forth. And you will likely have normal OAEs.
Yeah, and
right?
these kids actually are very difficult, right? They don't get benefit. It's hard to know.
So the otofurlin kids,
they do okay.
They actually do phenomenal with cochlear implants, for example. Right? So we know that that's also an alternative for them. And the problem that they were having in the beginning of the study was that they couldn't get a lot of people or, to be enrolled in, or kids to be enrolled in the studies because most of them were implanted already.
Right.
So that's something that's changing because they're offering to be enrolled early on. But you need to have profound hearing loss, cochlear microphonics, at least at first to have positive OAEs, right? The OAEs you might cease to have them over time.
Okay.
And then, of course, be positive for otofurlin.
And implant naive. Never.
And implant naive.
Okay.
That is huge. Yeah. So talking about implants, they're also looking at maybe including implants in the whole game in the future, not for the otofurlin.
Okay.
As far as genetic therapy and having it elude some kind of nanoparticles or something or have a channel where you connect to a pump in the future. These are studies that are still ongoing. Because, for example, let's say when you do implant somebody, there's always a risk of you losing your residual hearing, right? So if you have like that kid that we were talking about, you have that kid that has a normal or mild hearing loss in the low frequencies. If you implant them, yes, you have a chance nowadays with all the techniques and the implants are smaller, et cetera, of preserving that hearing.
Yeah.
But it can progress over time. And if it does, then you're going to have to turn on the cochlear implant in those areas instead of using, that's another thing that we should mention, you can use a hybrid implant, which is super cool too, right? So some folks are saying that maybe you can do genetic therapy to at least preserve those low frequencies as you're doing the cochlear implant too. So that's another thing we don't know.
Right.
It might be coming
there
down
may
the pipe.
be a combo role for an implant and gene therapy in the future.
Exactly. Yeah. No, exactly.
And so at this point, how do you counsel families that have a baby, right? This is going to be a baby with bilateral profound hearing loss that, went to genetic eval. They do have, they are OTOF. How do you counsel that baby?
We explain to them all the options, right? And I think as you can tell them what you know. So as I said, the results so far from these studies have been very positive, very amazing, really. But there's always a chance that it might not work and you might end up needing a cochlear implant. The other question that we had too when this all started was, okay, you're inserting something in your cochlea. Is that going to cause fibrosis? Is that going to preclude this child from getting a cochlear implant later on, right? And so far, they have not seen any of that. So some of the studies, they have done CT scans after, and they have not seen any fibrosis or ossification or any changes, which is great and very reassuring. So let's say you have to counsel them about all the known factors, possible risks, of course, like as I said, the risk of immunogenicity or of not working or needing a cochlear implant in the future. And it's a surgical procedure. We still don't know. We don't know. We don't know a lot of things, but I think it's so exciting.
Yeah.
Because if you're able to provide natural hearing to this child instead of them needing a cochlear implant, that's incredible. That's incredible. And I think that's opening the doors to a lot other studies and encouraging a lot of people that, we're going to be able to do this, which is crazy.
So are there other genes that are starting to be explored, or have we found other potential models for Connexin? Like, I think of airway and I'm like, oh, the pig.
Right.
The pig was a good model.
Right. There's a lot of studies, so many studies with very various genes. But I would say Connexin is probably going to be one of the hardest. But it's going to happen. It will happen. I don't know. Again, maybe I'll say this so we can jinx ourselves, like in a good way.
Right.
I don't know if I'm going to see this during my lifetime, but maybe.
Wow.
Yeah, which would be so amazing. Instead of having to counsel them about cochlear implants, you just say, hey, we have this option.
Right.
Can you imagine?
And there's different ways to access, however, to insert and apply the therapy. So it seems like even that might even get more streamlined and better and faster, potentially.
Exactly. And what's the least invasive? And absolutely. Absolutely.
So what are some of the challenges? You'd mentioned there's a lot we don't know in terms of genic response to longer term outcomes. What other, access, what other challenges do you see that based on just with your being part of the clinical trial, like, hey, we haven't thought about this, or this group of patients or these kids?
Most of the parents don't know about this. I mean, there's still a little bit of resistance, I would think, because this is something very new. The main issue, I would say, is that otolaryngology is rare, so to speak. So the
2%.
Right.
That's still decent, though. That's a good number.
Yeah.
I mean,
but the problem with otolaryngology, too, is because it's auditory neuropathy, a lot of times you're not diagnosed until later. Yeah. So we might see, this is, in my point of view, I think maybe the hardest issue is trying to diagnose them early enough so we can give them access to sound early enough. This happened with cochlear implants already for these kids, right? So here in San Diego, for example, we changed all the birthing hospitals to doing screening, newborn hearing screening with ABR, all of them. So we started diagnosing a lot more auditory neuropathy kids than in other areas. We actually had a study that we compared that with a place that only did mainly OAs and only ABRs for kids that went to the NICU. Yeah. So I would say that will be the biggest challenge, is trying to screen and diagnose them early enough so we can offer them early enough. So
yeah. In terms of going back to CMV, what are some of the newer, you had mentioned treatment options such as like vaccines. Talk to me about that, because that's another tricky one. That's a whole nother 2-part podcast in itself, which I'm like, why haven't we talked about CMV, congenital CMV?
We should. Yeah. Yes, that's huge, because it's 20%. Yeah. That's huge. And I think
it's variable too.
Right.
It's delayed onset, it's unilateral. It's a different.
It is a different category, altogether. But it does cause 20% of sensorineural hearing loss in children. And just exactly what you said. I mean, if we think hearing loss is invisible, congenital CMV is even worse. So, because if you have a child that have hearing loss and you have not done the test by 3 weeks of age, you won't know, right? And a lot of these kids are going to pass their newborn hearing screening and then fail later on, right? So I think for us ENTs, first of all, we need to make sure that we are seeing these kids early on. If you see them before 3 weeks of age, please test them for CMV. First thing, very fast. You can do a buccal swab. You can do blood tests. The gold standard is urine. It's not as easy to do, but is urine. And what they recommend too, if you're going to do the buccal swab, to wait at least an hour after they're breastfed, so there's no cross-contamination with mother's breast milk, right?
Because that's one of the transmission potentials as well.
Well, but not congenital CMV. You're going to have it since it's in utero. It's in utero. So that's So you don't want to. If mom still is positive and the baby's not, you might think that they're positive, if they're breastfed.
Got it.
Right.
Okay.
So, yeah. And then there's a lot of talk about this, about how to prevent congenital CMV, because, just don't. Little kids are going to have a high incidence of having CMV. It's like a cold. Everybody does. You don't want to catch it when you're pregnant. So if you have a younger child, try not to, use their utensils or kiss them in the mouth or, any contact with saliva. Try to reduce it as much as possible. It is horrible. I know.
It's really hard.
I keep thinking about this. I'm like, oh boy. But so that's where the vaccines come in. So there's a lot of trials going on right now. I think this is going to be a huge game changer. Just like we're talking about the genetic therapy for hearing loss, the vaccine for CMV will be huge.
And who are they going to give that to?
To the moms.
To the moms.
To the moms. So if you can prevent them from contracting CMV, then they're not going to be able to pass it on to their kids, right? So that will be, I think, the biggest game changer.
And how are they going to, is it going to be, oh, I'm pregnant, so now I got to get the vaccine? Or is this going to be part of women's health potentially? Or how do you?
I don't know what they're planning. The only thing that I would say, if it does come out, everybody should do it. Because, 20% is huge.
Right, it's huge.
And it's not just a hearing loss. Congenital CMV can cause so many other issues. Developmental delays. You name it. And it can be deadly as well, right, for the newborn. So that will be huge. And I think if you look at the kids, for example, that have congenital CMV and have cochlear implants, their outcomes are not on par with kids that have, for example, connexin 26. So there's probably some kind of developmental issues that play a role there as well. I'm just very excited to see this vaccine come out. So that'll be one thing. And then the other thing you mentioned, which is the treatment. So there's a lot of studies too, and Kimberlin, and they did a phenomenal job in looking at treatment for kids that have sensory nerve hearing loss caused by CCMV. So that the treatment should be done for 6 months. The earlier, the better. And it's with Volga and cyclovir. Yeah. The thing is, it's not an easy treatment either.
Right.
It is not easy. So
are they checking liver what labs?
You have to do CBC. You can have neutropenia. There's a lot of side effects.
And
too.
Is that can be managed by ID or is that?
Yes.
Yeah.
I always say that I'm not smart enough to do it.
Yeah.
You need a team.
Is that, we want to try to do the testing within the first 21 days. But as we know, a lot of times we don't get diagnose the hearing loss until months later or a year or two later for that treatment. Like, let's say you then did call the dried blood spot, call the lab to see, and they do have that. Or maybe they had MRI brain and some imaging that shows, and you're like, okay, this looks like CMV.
Mm-hmm.
Is there a age range for that 6 months of valcyclovir? Or is this for that congenital, found within that first 21 days?
Ideally, you want to start the treatment before 3 months of age. They have not seen benefits, over the risks if you do it later on. But again, all these things are there are trials and tests and so forth. But right now, if you can do it by 6 months, I would say, and that's pushing it already. You have to have a really good discussion with the family. And again, it's going to have to be with your ID colleagues, because I think we work with them. I have a very great relationship with our ID folks, and we do it with our audiology as well. But it has to be through them, because it's a lot of checking. You have to check very often the blood tests and so forth.
Yeah. At hospitals or at Rady's, once you have a failed newborn hearing screen, and usually sometimes, they don't automatically start testing salivary PCR. Or is there a reflex test for that in some places or programs, or how does that working?
So there are a few ways of doing this. So first, I would say that the most common when there is some kind of testing is going to be targeted screening, meaning exactly that. So if you fail your newborn hearing screening, you have the test done. That's your best time to do it.
And is
right?
that up to the the pediatrician and the well nursery baby or the NICU doc or the audiologist then tells them to, like, how does that, at Rady, is there a pathway?
Yeah, so we also changed all the hospitals here. And I would say I have to mention Albert Park because he is phenomenal in being like the advocate for CMV. So big shout out to him.
He's in Utah?
He's in Utah.
And they have part of their universal newborn screen
I think
CMV,
they do.
or?
I think they're still doing targeted.
Okay.
But then they have their pediatrician's tests as well.
Okay.
Yeah. So there are a few states that have universal, meaning all kids are tested despite failing the newborn hearing screening or not. There's a study that showed that when you do targeted screening, you're missing a lot of kids also.
Yeah, because it's not going to present, right?
Correct.
We know it has delayed onset.
The late onset ones and so forth. But then the counterbalances with universal is what to do with that information. I think that's super important. I mean, you can follow those kids. Even if they don't develop hearing loss, you keep an eye on them. And even if we're not treating those guys, right? Because we're not going to submit them to therapy if it's risk benefits again, right? But so universal screening, targeted screening, and then, so here in San Diego, we're able to switch everybody to doing targeted screening, which is something.
That's something, yeah.
It's something.
Well, it's awareness, it's education, and maybe you're going to still get some more patients that you can help. And it's such a big impact, right? Like,
absolutely.
So as we start to round things out, Daniela, where do you see future research or applications when it comes to congenital hearing loss? What's your wish list of what you'd like to see?
So, I love that question. So I think, it would be great if we could make first genetic therapy available to the most common genes. That's the first one. So connexin would be my biggest one in the wish list. And also make it just easier to do. So if we could prevent them from having big surgeries, if we can make it really simple, and even I know that they're creating these micro needles to go through the round window, all these different things. Maybe we can go through the TM, then a round window.
Yeah, I'm like,
something like that, Is
this going to be like the hummingbird, but just go deeper?
Right? Yeah, just go a little bit further. Just do what you shouldn't do, right? I know. So I think that would be amazing. That would be amazing.
I mean, it's crazy if you think about how something it could be so simple-ish, but
I know. And as I said, I mean, 3 years ago, this was a moot point in my conversations with the families. They would come in, and I'm like, sorry, there's nothing really available. And now I'm like, hey, guess what?
Yeah,
there is. So and also in that regard, when they ask nowadays, okay, so I heard in the news, because I'm sure a lot of the ENTs out there, I heard in the news that there's genetic therapy for hearing loss. I think we need to explain to them it's a very small percentage of the kids, and you need to have this very specific genetic mutation, but it's happening.
Yeah.
It's happening. It's so exciting. I can't.
That's awesome. Any final pearls you want to leave our listeners with?
Well, I think the most important thing is to, now that this is happening, is keep reading, stay updated, because it's going to be fast and furious, I think.
Yeah.
There's going to be a lot new things coming down the pipe, and just make sure that you know what's the latest and greatest, because your patients are going to be asking you questions. So,
it's true. It's in the lay media as well as all of, many of our publications, peer review. So it's pretty cool.
Absolutely.
Are you on any social media, Danielle, in case any of our listeners want to reach out to you?
Yeah, so I am on Instagram, but I'm terrible at Instagram. My kids make fun of me too, but maybe I should be more. Yeah, but they can feel free to email me on my Rady's email. I'm happy to discuss this at any time. It's so exciting. So
awesome. Well, thank you so much. I learned a ton, and thank you for taking the time and sharing your experience with us.
Thank you for having me. This has been super great. As you can tell, I'm very passionate about this. And thank you. What you do is phenomenal. So thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.